Maybe we should talk about some of the things that hyperosmolarity does, looking at the ocular scatter and how it affects your vision. Osmolarity correlating with visual function. So this looked at patients who had an osmolarity of, the average was 284 in this group and 326 in the other group. They looked at an ocular scattering score in patients with normal osmolarity versus high osmolarity. And as you can see with the normal group, they had a very low score and it was stable over time. Wasn't nothing happened really with the use of artificial tears. We looked at, or they looked at, the abnormal group, and as you can see, their ocular scattering score is all over the place. Then a drop of artificial tears was instilled, and after 5 minutes, you can see a lowering of the scatter and a more tightening of the curve, and after 15 minutes, it was basically flatlined.
All these tests require a pristine ocular surface. Otherwise, they're going to give high abnormalities, irregularities in the corneal topography, and aberrant readings in the keratometry to properly select an IOL power, as the phaco study showed. If I see any abnormality, we don't really do the testing that I'm going to base my IOL measurements the day they come in. We look at them all to know like what lens to maybe present to the patient, and then I'm going to say, well, that corneal surface is abnormal, so we're going to initiate therapy based on our markers such as osmolarity, and then see them back for repeat advanced diagnostic testing and reassess their ocular surface.
If the topography doesn't correspond, if the Ks don't look right, if they have irregular Myers, if they have high osmolarity, I want to start getting them treated. And I will reference this ocular scatter. And I explain to them that the tear film is important both preoperatively to get good measurements, but postoperatively so they understand why they're having aberrations. We do use the osmolarity perioperatively. And then postoperatively, when you get these patients who are complaining, I think it's important to go ahead and check it again, because a lot of times they've been on post-op drops for weeks. They've been on a steroid, they've been on an antibiotic, they've been on a non-steroidal possibly, and these preservatives may be irritating their eyes. And it's very useful to be able to say to them, well, look, you're a 326. We know what this does to your scattering of light. You need to get this cleaned up, and then let's hold off on giving your post-op glasses and see where you end up.
I use the test to tell the patient that 70% of their problems are cataract and 30% is their dry eye. And you want to tell them that pre-op, that their dry eye is affecting their vision. Because as soon as you do their surgery and they remove their windshield and their eyes hit the air more, what do you think their osmolarity is going to do? They're going to get one level worse.
I agree that a lot of the patients that come in have their visual complaints aren't just from the cataract, it's also from dry eye. And I'm sure we're all going to nod our heads, but how many times have you guys seen a patient where you've treated their dry eye, bring them back for their final pre-op screening, and something they're seeing better and they don't need surgery? And they're actually pretty happy.
That's happened quite a bit.
Yeah, so that can happen. Patients are very happy and appreciative, and they're like, and they come back in a year, and eventually they'll have it with you, but they feel really good that you weren't there just to, move forward with surgery right away, and that you really figured out their condition.
There's no doubt a suboptimal surface is the harbinger of a bad outcome, either in cataract surgery or refractive surgery. And priming the ocular surface is so important. So having numbers is important, fluctuating vision, the quality of vision, all the numbers you've talked about before, and post-operatively, it helps mitigate those surprises that occur, either refractive surprises or surface surprises. The ocular surface is a very important part of our surgical planning, and if I have to then procrastinate in the decision to undergo cataract surgery, at least a patient is afforded that intellect that it's worth the wait of a couple of months. And like Bill said, maybe 10 or 15% of patients are like, you know what, I'm actually seeing quite well now, let's just hold off for a couple of months. And we're okay, and guess what? They brought 10 more patients to practice. You know what? That doctor didn't rush to my cataract surgery.
We're in a very outcomes-based society now. That's the way healthcare is moving. So if we're talking to a very busy general ophthalmologist in the community about why it's important to do some dry eye screening before cataract surgery or LASIK surgery, really what we're talking about is driving better outcomes. We're going to improve our refractive predictability. We're going to make for a more rapid visual recovery. Like an attending of mine told me, the problem you find before surgery is the patient's problem. The problem you find after surgery, that's the doctor's problem.